Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, we discuss best practices in screening for hepatitis B and Delta, as well as treatment for hepatitis B. I'm joined by three faculty, Dr. Patricia Jones, Associate Professor of Clinical Medicine at University of Miami Miller School of Medicine, Dr. Mindie Nguyen, Professor of Medicine of GI and Hepatology and Liver Transplant at Sanford in California, and Jennifer Wild, patient advocate for hepatitis B, as well as a clinical nurse at UCSF Cancer Center in California. This episode is part of a larger educational program titled Paths to Elimination, Simplifying Screening and Treatment of Viral Hepatitis in Priority Populations. For more information on Drs. Jones and Nguyen and Jennifer, along with the link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started, starting with Dr. Jones.
We'll talk about hepatitis B screening, and I want to highlight some of the updates. So these are from the Centers for Disease Control and Prevention. And back in 2008, we used risk factor-based criteria using surface antigen only. Fast forward to 2023, where now the CDC recommends universal screening of all adults at least once in their lifetime. And this is important to note the change because where in 2008, surface antigen was the test that was recommended, now the triple panel test is recommended. And the triple panel test consists of hepatitis B surface antigen, hepatitis B surface antibody, and total anti-Hep B core antibody. In addition to universal screening at least once in a lifetime, risk factor-based screening is also recommended. Pregnant persons should be screened in the first trimester because this allows for identification of individuals with hepatitis B who might require treatment to decrease the risk of transmission, and we'll talk a little bit about treatment with Dr. Nguyen later, and then continued periodic risk factor-based testing. So some individuals with characteristics that might place them at higher risk include individuals who are or have been incarcerated, individuals with a history of sexually transmitted infections or multiple sexual partners, and anyone who has a history of hepatitis C. So we'll go through the summary of other guideline recommendations, and we'll spend a little time here just to highlight the fact that there were a lot of variability in terms of the recommendations from guidelines, which leads to varied practice. So for example, in 2018, the AASLD guidance recommended risk-based testing, and they recommended testing for surface antigen and surface antibody. And so those are people who have risk factors, which could include, in addition to those we've mentioned, those who are incarcerated, individuals who use drugs, individuals with a history of sexually transmitted infections, also includes people who were born in countries that are highly endemic for hepatitis B or have intermediate endemicity for hepatitis B. And that's very challenging because it's difficult for clinicians to really know which countries have high endemicity or not. And we'll get into that in more detail later on. In addition, FAASLD recommended risk factor-based testing, but they recommended what we now call the triple panel test. Whereas EASL, the European Association for the Study of the Liver, didn't really specify whom to test, except for pregnant persons and candidates for immunosuppression, and also didn't specify how to test, followed by new World Health Organization guidelines in 2024, which recommended risk factor-based testing with surface antigen. So let's talk about hepatitis delta screening. So many know that hepatitis delta is an infection that only occurs in individuals that have hepatitis B. It's often thought of as a faulty virus or a defective virus. And the reason is that it requires hepatitis B surface antigen to actually assemble. And so it really can only impact people who have hepatitis B. And so the universal screening recommendation is that those individuals who are surface antigen positive should be screened for hepatitis delta with an anti-hepatitis D test. Anti-hepatitis D positive patients, that is those with an antibody, should have HDV PCR testing with an RNA test. But as we talked about some of the variation in the guidelines or guidances of various professional societies, this is a similar situation that we see with hepatitis delta. So again, the European Association for the Study of the Liver in 2023 recommended testing all patients with hepatitis B and recommended the hepatitis delta antibody as well as the HDV RNA, whereas the American Association for the Study of Liver Diseases, or AASLD, recommended testing patients who have surface antigen positive and risk factors for HDV. So that might be being born in a country where hepatitis delta is endemic. And this presents a lot of challenges because there's actually limited information on the epidemiology of hepatitis delta based on low screening rates. So oftentimes people think of the Mediterranean as predisposing one to be at risk for hepatitis delta, but we've learned that there are actually many regions that have higher risk of hepatitis delta that wasn't previously known. Another situation, a clinical scenario where you might order hepatitis delta would be in someone who you would think should not have abnormal liver enzymes. So for example, a person with chronic hepatitis B who has either low or undetectable HBV DNA, but for some reason a high ALT should prompt you to look for other causes. And so the AASLD back in 2018 recommended testing again with HDV antibody or HDV RNA. APASL, the Asian and Pacific Islander Association, recommends testing patients with chronic Hep B and chronic liver disease. And this is similar, the Hep delta antigen or anti-HDV antibody. So they recommend either or as an option rather than just the antibody as the first test. And just to highlight, the World Health Organization in 2024 now recommends testing all patients with hepatitis B and using HDV antibody with reflex HDV RNA. So I think that's important to highlight the change over time. So reflex HDV testing. I think we've become really familiar with reflex testing and other infections. For example, oftentimes now when hepatitis C is tested via an antibody, it reflexes to an HCV RNA, and that's actually pretty standard in commercial laboratories. And so the idea is that if you do reflex testing, it would obviate the need for a patient to come back in for a follow-up blood work. So it might help avert some of these challenges where patients could be lost to follow-up. So here's some steps along the continuum, as well as potential areas that patients could be lost to follow-up and that reflex testing could actually help us to avoid. So in step one, the patient will have a new patient visit with the provider. They could be lost between actually getting the blood work done. But if they get the blood work done and they're found to have hepatitis B, then there's a potential there to actually reflex everybody who is a surface antigen that's positive to have automatic HDV antibody testing. I will say that availability of HDV testing depends on facilities and labs. So it's important to reach out and try to understand what your location offers. In those individuals who have a positive anti-HDV antibody test, then there's additional potential for reflex to automatic HDV RNA testing. Again, patients could be lost to follow really at any point before they see the provider for management. But you can see we can, by doing reflex testing, avoid even more follow-up, loss to follow-up. So now we're going to transition to a discussion. I invite my panelists to join as we discuss what are some of the barriers we experience with implementing Hep B screening, and also how we've incorporated updated guidelines, and what might we encounter as barriers to implementation. Dr. Nguyen, do you have any thoughts about some of the barriers to implementing HBV screening?
I think the list can be quite long, but a lot of it, I think, is either low awareness, either of the hepatitis B infection risk as well as the risk of hepatitis B. Sometimes I hear from my patients that, oh, I come from, let's say, China or somewhere in Africa, everybody has it, and they seem okay. So it's a false sense. It's a silent disease. As you know, patients are pretty asymptomatic until they get like liver failure or end stage liver cancer, very late stage. So it's mostly, people call it a silent killer because the patient is asymptomatic until maybe just in the last some months of life. So I think some is complacency that could improve, I think, with both provider and patient education and the purpose of what we are doing today. And HBV is more common and high prevalence than many people think. And in studies that looked at ads for why people don't get screened, some of the answers can be that there's nothing to do about it. So not everyone is aware that we have very well tolerated, very safe, and very effective medications for hepatitis B, among other things. For some patients, it may be cost, but data have shown people with commercial insurance, so Hep B would be covered, but people still not diagnosed, and some may be stigma. Maybe people don't want to know.
Yeah. I just will add on to some of the comments that you made in terms of the barriers that I experience as well. And I agree. I've heard from patients that well, a lot of people have this and this isn't a problem. But I think one of the major things is it really is education and awareness about the fact that this can lead to really bad outcomes like liver cancer, even before it leads to things like cirrhosis. Because oftentimes, I think when we presented data from the market scan, about half of those patients with HCC were on treatment for Hep B, which really is like a proxy for whether or not they had actually known about the infection. And in our center, many people are diagnosed with HCC and Hep B at the same time. And so barriers to implementing screening, I think most communities, it's cost and insurance, access to healthcare providers, and then knowledge about whether or not it's recommended. I think the universal guidelines will really help, because I hope that will lead to automating some of the orders that are needed. For example, in the primary care setting, people don't have to now know where people are from. They can just, if it hasn't been checked before, they can place the order, and even order sets, for example, for a triple panel could be done. And I think that'll overcome some of the barriers that we experience, both in the community and in academic settings. Any considerations for screening for hepatitis Delta virus? Do you have any thoughts on that?
I think that really depends on your population. Some colleagues around the country, I'm aware they see quite a bit of hepatitis D delta, but I actually routinely check hepatitis D delta in all my new patients. But I have to say that the majority in the Bay Area here of our hepatitis B patients are Asians, and I have yet to diagnose a Hep D in an Asian patient yet. Some of them have positive antibody, but the RNA is negative. So the handful of delta that I have, they come from areas where you would expect, from South America, from Eastern Europe, and such. But it is my practice for the last 25 years that I check in everyone, because just in case. And it would change our practice in terms of being monitor the patients. It may change my threshold to initiate antiviral for hepatitis B. And until recently, now, we expect to have FDA-approved medication in near future for hepatitis D delta. So I think we really need to look for these patients, even when the community is low in prevalence. You just have to check. If you don't check, you will never find it.
Agreed. And I do my best to check in every patient. There are some times that I do notice that there are challenges with actually ordering the test. And this actually tends to be timed around updates of our electronic medical record, where you can order and then all of a sudden the order isn't linked to a lab, and then we have to sort of get a ticket to fix that. But I actually have a few patients that do have hepatitis Delta. Personally, I've been practiced for 10 years. I have about 3 patients. So I do think it's like you said, if you don't look, you won't find it. And then we won't have as much information about the epidemiology, but just knowing that it can worsen outcomes in patients, for me, is all the reason to check it.
So with that, in the coming years, we all hope that more patients will be diagnosed. And if we will repeat our study in the coming years, the diagnosis rate hopefully will not be 18% anymore. Hopefully something much better than that. Now, once the patient get diagnosed, you could see from the data that even people with really severe complications, cirrhosis and liver cancer, only 1 in 3 or 1 in 2 of these people receive antiviral therapy that have been proven and shown again and again to improve their survival even after they develop such high complications. So treatment, who to treat, how to treat, and what should we do after the patient get diagnosed. So let's go into treatment pathway. So this is a 2024 release in late March 2024 WHO recommendations. So this recommendation, I believe, is really one of the breakthroughs for hepatitis B management, because for the first time, it really help simplify many things. Number one, there's nowhere you can find E antigen. So E antigen is no longer a criteria for treatment with the WHO guideline here. So treatment is recommended for everyone aged 12 or older with any of these followings. Okay, so any of these is not an. So if the patient have significant fibrosis or cirrhosis, so generally significant fibrosis is stage 2 or higher, 2 out of 4 or higher. Advanced fibrosis is 3 or higher, and cirrhosis is stage 4. And based on these markers here, it can be by, any evaluations, but the WHO gave the specific APRI score more than 0.5 or transient elastography more than 7 kPa. But non-invasive tests like ultrasound elastography, the FIB-4 and other things, even though not mentioned here, could also be considered. And cirrhosis based on clinical criteria, if the patient have any varices, ascites, or a nodular shrunken liver on imaging, or APRI more than 1 or transient elastography of 12.5 kPa or higher. So very clear cut. So regardless of ALT level and regardless of E antigen, we don't even need to check that. Regardless of ALT levels, if the patient has significant fibrosis here or cirrhosis, and even DNA does not need to be checked. As long as surface antigen is positive, it's recommended for the patient to be checked here. If the patient does not have known significant fibrosis, so fibrosis tests show that the fibrosis is only 0 or 1, but if the patient have DNA more than 2,000 or ALT more than ALT at any abnormal level at all, abnormal level for men is more than 30 and for women more than 19, not what the reference lab range in whatever the reports that we receive say. So this is very important. Previously, these patients would be considered like in the gray zone or indeterminate according to the various guidelines, the American AASLD guidelines or even the EASL guidelines. So a lot more patients now would meet treatment criteria according to the WHO recommendations here. And then the patient could also be considered for treatment even if their ALT is normal, if they have additional risk factors that would make them at higher risk for future complications. One of that is co-infections, HIV, HCV, or HDV. HCV and HIV already universal screening recommendations by the CDC in the US for many years. And that's why today, a few minutes ago, we focus on advocating for HDV screening as well. Or if the patient have a family history of liver cancer or cirrhosis, or, in my opinion, if they have family with liver disease, in developing countries, things don't always get tested and diagnosed. But if the patient has a history that my father died of liver disease, and, if it's not an obvious history of severe alcohol use, etc., then, it's fairly safe to assume that it's likely to be one of the endemic viruses like Hep B or Hep C. Immune suppression. This is important because we know very well in the transplant literature that if the patient is immunosuppressed, as transplant patients would be, then the fibrosis progression is much faster if the patient get reinfected with either hepatitis B or C before the liver transplant. So immunosuppression is a risk factor because these patients would be at higher risk for disease progression to advanced fibrosis, cirrhosis, and liver cancer. Immune surveillance for cancer is very important. Our immune surveillance is not just for infection, but also for cancer. And then comorbidities. Data has not always been consistent, but there are data to suggest that patients who have fatty liver may be at higher risk for liver cancer. Diabetes is a clear factor. Data is very consistent in that diabetes patient is at higher risk for liver cancer in patients with hepatitis B. This has also been shown for other liver diseases as well. Or if the patient have extrahepatic complications of hepatitis B, like vasculitis or kidney nephritis. These are quite rare, but as you know, fatty liver and diabetes are very, very common in the populations, increase with age and will continue to increase with the continued epidemic of obesity. So I would really advocate for everyone to think about this, that you may have seen and may have heard the prior recommendations that are much more complex, and I will show you in a little bit here. But these, which I believe are much more inclusive, and even though there may not be randomized controlled trials for some of these, we have had the test of time that we have had oral medications for hepatitis B, and the top line medications at this time, such as entecavir or tenofovir, have been around for 20 years and have had excellent records of safety. So risk versus benefits is something that we need to weigh in, and I believe that went in the WHO consideration, and that's why they came up with these recommendations. And we also get simplified treatment recommendation for patients who are pregnant. So for developing countries, the reservoir of infection are mostly from people who contract this, either from their mothers or very early childhood, from horizontal transmission from living in crowded environment with people with hepatitis B. So the recommendation now is to use TDF, which is the older form of tenofovir, because this has been studied and actually has lots of real-world experience. I checked recently the antiretroviral registry for mothers taking TDF during their pregnancy and the outcomes in the babies. And currently, though, it's almost 5,000 people have been exposed, and data that we have to date show that the birth defects rate is not significantly higher or different from the general population. So the recommendation is, if the patient is surface antigen positive with DNA 200,000 or more, or positive e antigen, you don't need to even check surface DNA or wait for it. So if e antigen is positive or DNA 200,000 or higher, TDF, tenofovir, is recommended. And recommended, the timing here is second trimester of pregnancy until delivery or completion of the infant HBV vaccination series. So second trimester go up to 24 weeks. In my opinion, it doesn't need to be started at 13 weeks, beginning of second trimester. I would wait toward the end of second trimester, or if the viral load, let's say somebody, if we know the viral load and the viral load's in the billion range, then I think an earlier, like early third trimester or late second trimester, may be needed to drive the virus level down by the time of birth. But if the patient has a virus level, let's say 500,000 or 1 million, it's not very high, these patients could wait until 28, 29 weeks. We have very good safety records for TDF, but still, it's always err on the side of being more cautioned, would be my opinion. So one criteria is E positive or DNA 200,000 or higher, or if the patient is surface antigen positive, but we cannot get DNA level or E antigen level, and it could be that we are seeing the patient at a late stage, like 38 weeks or something like that, and no time for HBV DNA. And if the patient is interested in treatment just to be on the safe side, then, in this case, the WHO give this conditional recommendation. They're probably not sufficient data, but, this is in the interest of trying to prevent as much transmission as possible. In the US here, we should have access to e antigen or DNA in the very vast majority of cases. So generally, we would not need to have to use this conditional recommendation, at least in Western countries, in areas with a little bit more resources. Okay, so this is a summary of the other current guidelines, and I want to also mention here that both the EASL, which is the European Liver Society, and AASLD, the American Liver Society, both are actively trying to update this. I do not know. No one knows yet, even though I, may participate in some of these. None of us know yet until it's done. The general consensus is that we do need to try to expand, but how expanded, no one knows yet at this point yet. We do hope that the new guidelines for the American Liver Society, AASLD, and the European EASL Society will be available in the near future. For now, the most updated is the WHO that I just shared with you, and these are the older guidelines that will be updated very soon. E-antigen is still part of the algorithm, and 2 times upper limit of normal is also part of the algorithm for the AASLD, the American Liver Society, and also the Asia Pacific, and increase just high upper limit of normal is for the European Society. And many experts in Asia, for example, like in China, Liver Society have been calling for treatment for all patients who are positive for HBV DNA. So there are many different opinions and try, but I think the agreement is that the current guidelines should be expanded, and the WHO guideline that came out last year really helped expand the treatment for many patients who are at risk with hepatitis B. Okay, so now we are getting to faculty discussion section. We did a study at Stanford Liver Clinics and at 3 GI community practice in the Bay Area and a few PCP practice in the Bay Area. And we looked at the people who met criteria for treatment by lab tests, etc., and then the percent of those patients initiating treatment within 1 year after meeting criteria. And we found that only about 60-70% of these patients got started, and we did not see costs. Cost is the problem in only a very small fraction of patients. But then again, most of these people are in care already in GI and liver practice.
So I think you're right. People who already are in care have already crossed several thresholds, typically have insurance, may have excellent insurance that allows them to be seen at academic centers. I have found costs to be a major issue, not only with starting medications, but continued adherence to medications. This time of year is always challenging, and I always give a speech to patients that sometimes benefits change the beginning of the year. And sometimes medications that were affordable become less affordable, and to let me know if that happens when they go to the pharmacy. But certainly cost has led to several of my patients, especially those on Medicare, to stop taking treatment. And I'd say another barrier to uptake is sort of the idea, as you mentioned, that this is sort of a silent disease. People don't feel bad, but the idea that they might need to be on medication for life is often a barrier to some of the patients who are engaged in care wanting to start treatment. And so those have been the major barriers that I've had, is making sure that people can afford it. I will say there's been definitely some facilitators. The cost of the drugs has gone down significantly, some of them, since when I first started back in 2015 as faculty. And that's made it easier. But still, for some patients, cost is a major consideration. And just not wanting to be on medication is a challenge.
Yeah, I agree with the cost issues, especially after the COVID pandemic. I think because it's an asymptomatic disease for many people, that when some people had to make choices about, well, what can I afford right now? What's more important, my blood pressure medication or my Hep B medication? Well, which one is making me actually feel crummy? And so I think when people had some cost decisions to make during difficult economic times in the last 5 years, this is one of those things that maybe gets the axe more because it's not symptomatic.
So let me ask you some more follow-up questions on it. So cost is a problem. Is it because insurance doesn't approve or because of the copay?
Generally, the copay. I think that insurance approves treatment, but it's the copay that the patient is met with. when they go to the pharmacy. And so some of the solutions like GoodRx's, sometimes we'll look for that, copay cards, for example. And then honestly, with the advent of generic TDF, it's been a lot easier for certain patients. But I definitely have patients that will tell me astronomical numbers per month that they simply can't afford to pay. And there's really not a whole lot I can do besides those resources.
Yeah. And I think too that probably all three of us remember when there was the petition circulated by the Hep B Foundation to get signatures from healthcare professionals trying to urge insurance companies to start covering tenofovir. And so even when it is approved on formulary for these prescription drug coverage plans, a lot of times it's like a tier 3 or 4 or specialty tier drug. And so patients might see it in the covered drug list, but only when they go to fill it do they learn it's a high tier cost. So instead of a $5 copay, it could be hundreds of dollars.
So I guess in my experience, the main thing is the copay, but then the copay is mainly because the brand medications, and I always use generic. And right now, both entecavir and tenofovir, they are generics, and very, very rare cases that they may need to get the newer, the tenofovir if they have obvious kidney and bone problem. But the vast majority do not need that. So I have been just using generics. So copay, I have not had problem. In fact, I don't think I have any Hep B patient of mine. And I also go to an outreach clinic in the community in South San Jose, and it would be covered. And usually the generics, the copay is a lot less. Now, there are some patients have the type of insurance that do not pay for anything until they reach their deductible. So that is like something else that I don't think there's not so much we can do about that. And that would also involve, we would also have problem with blood tests and such. So some of the patients, they know that, because they have Hep B, they need to get blood tests and ultrasound and other things that they would reach the deductible anyway. So usually the patient with more comorbidities that they would reach the deductible anyway, then they would just, spend it. But the patient who are healthy and younger, and they feel that, without Hep B, they don't need to reach their deductible. So it's a bit of a J-shaped curve. And we've done studies to look at this. The adherence is a J-shaped curve. People with a lot of comorbidities and spend a lot, they're actually more adherent because I already spent it, meet their deductible. For some of my patients, I have many patients who are lower income, then they actually, we can help them apply and get the patient assistance copay. So it's a lot of hoops for both patients and providers to jump, over to get it. But in our studies that we reviewed the charts of the 30% of patients who didn't initiate treatment, actually the most common reason that we saw was one, patient don't want to take it forever and hesitate, just like you mentioned, Patricia. But a lot of it is also physicians thinking that the ALT is not high enough and wanted to observe some more. So we kind of touch, on some of the potential barriers, and I think that if we move on from here, there will be some specific suggestions and experience that we can share on how to overcome some of these things.
Thank you, Dr. Jones and Nguyen and Jennifer Wild, and many thanks to you, our listeners, for joining in. As a reminder to view the full program, Paths to Elimination, Simplifying Screening and Treatment of Viral Hepatitis in Priority Populations, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.